Okay. So, afternoon, everybody. I'm Dr. Sushant Soni. I'm MBBS FMC, MD Pathology, Resident Hemato-Oncology, AIMS Delhi. So, let us start with our next discussion, our next mid-year discussion, that is the JIPMER June PGI, JIPMER June 2020 pathology discussion. Now, before we go further, with respect to pathology, the JIPMER exam, it was a very satisfactory paper. There were about 30 to 32 questions in pathology in JIPMER. Majority of the questions were covered in the notes and in my pathology MCQ book, and the new questions were hardly one or two, hardly, and that too, if you had just missed out on that topic. Rest, it was a very satisfactory paper with respect to pathology. I had numerous students tell me as such that, sir, it seemed like pathology will be the most important rank deciding paper or the rank deciding subject in JIPMER, firstly. Secondly, astonishingly, we did not have that many images in this exam. So let us go forward. Let us go forward and start with our first question, that is autophagy is or true in autophagy is, and the answer is C. And the answer is C, that is, it is degradation of damaged proteins and organelles. Firstly, autophagy, it is of three types. Again, as usual, we had four topics. Dekho, I'm the only pathology faculty with whom we discussed everything. The PGI mid-year exam, the AIMS mid-year exam, as well as this is our third discussion, the JIPMER exam. Four topics were repeated in common in all three. So we will be having a look at each question in detail. This discussion will form the prospective questions for your November AIMS as well as the NEET 2021 exam. So autophagy, it is of three types. The first is the chaperone mediated autophagy. Chaperone mediated, in this there is direct translocation across the lysosomal membrane by chaperone proteins. The name tells you chaperones, they take the material across the lysosomal membrane. They are helping in chaperoning the material across the lysosomal membrane. It is direct translocation. The second method is microautophagy, that is inward invagination of the lysosomal membrane for delivery. If this is the lysosome, there is inward invagination of the lysosomal membrane for delivery. And the last and the major form of autophagy is the macroautophagy. Macroautophagy, it involves sequestration and transportation of portions of cytosol in double membrane bound autophagic vacuoles. Point to be noted is the autophagic vacuoles are double membrane bound, and it has the following steps. That is, first, the cytoplasmic organelle, there is a nucleation and an initiation complex, that is initiation. In turn, initiation is associated with formation of an isolation membrane called as phagophore. Called as phagophore. This is the next prospective NEET exam question. What is a phagophore? It plays a role in initiation in autophagy. Next point, its nucleation and isolation membrane is believed to be derived from endoplasmic reticulum. So where is it derived from? ER, endoplasmic reticulum. Followed by elongation, maturation of the autophagosome, its fusion with the lysosome, and degradation. These are the steps involved in autophagy. Lastly, autophagy, it plays a role in cancer. It plays a role in cancer. In neurodegenerative disorders, plays a role in cancer. Neurodegenerative disorders like Alzheimer's disease and Huntington's disease. Alzheimer's and Huntington's. Infections like mycobacteria, Shigella, and herpes simplex. Infections and IBD, that is inflammatory bowel disease. You very well know IBD is of two types, Crohn's and ulcerative. You know that. Next point. This gets us to our next question, that is pyrogenic mediators are all except easy 1 2 3 4. Answer bache, TGF beta. The most potent pyrogen is interleukin 1, followed by interleukin 6, followed by prostaglandin E2. Ciliary neurotropic factor is also a pyrogen which belongs to the interleukin 6 family, which belongs to the IL-6 family. Next point, TGF beta, transforming growth factor beta, is an anti-inflammatory mediator. It is anti-inflammatory in nature. Throughout inflammation, we study cytokines and chemokines which cause inflammation, except three. which are interleukin 10, TGF beta, transforming growth factor beta, and lipoxins. And lipoxins, they are anti-inflammatory. Next point. Not a cause of endometrial cancer, not a cause of endometrial carcinoma. Answer: OCPs. OCPs, oral contraceptive pills, reduce the risk of endometrial carcinoma. Next point, infertility and tamoxifen increases the risk. Now, the main point here is I can divide endometrial carcinoma into two types. This table that we are making is important for NEET. We can divide it. We can divide it into two types. That is type 1 endometrial carcinoma versus type 2 endometrial carcinoma. First point, type 1 endometrial cancer. This has a background of, this occurs in a background of prolonged estrogen stimulation. This occurs in a background of prolonged estrogen stimulation. Firstly, next, it is seen in elderly, that is 55 to 65 years of age. 55 to 65 years of age. Microscopically is most commonly endometrioid type. Microscopically is endometrioid type. Has a favorable prognosis. And the gene mutation associated in this is the P10 gene. And the gene mutation associated is P10. Present on chromosome P10, which is the new molecular policeman, chromosome 10q, long arm of chromosome 10. Versus the type 2 endometrial carcinoma, versus type 2, which is not associated with hyperestrogenism. First point, it is not associated with hyperestrogenism. Type 1 had a background of prolonged estrogen stimulation, type 2 does not. Occurs in more elderly. Age group is more elderly, that is approximately 70 years. Is associated with a poorer prognosis. Thus, microscopically, it is the serous or the clear cell type. Microscopically, it is either serous or the clear cell type. And lastly, the gene mutation. It is associated with P53 mutations, which you very well know is chromosome 17p13. P53 chromosome 17p13. Next point. This gets us to the next question, easy one for that matter. Patient with reticulocyte count elevated, and features of hepatitis with reduced hemoglobin, abnormal behavior and movements. MRI has dense deposits in basal ganglia. This was the most important line in the whole question, dense deposits in basal ganglia. Likely diagnosis. Answer, देखो बच्चे, hepatitis with deposits in basal ganglia, Wilson's disease. I'm sure majority of you would have been right in this, Wilson's inheritance pattern. Let us quickly have a look. Autosomal recessive. Age group is 6 to 40 years with an average of 12. You know that. Mutation, ATP7B gene mutation present on chromosome 13. Versus hemochromatosis, which has most commonly HFE gene mutation present on chromosome 6p, short arm of chromosome 6. Wilson's ATP7B gene mutation, chromosome 13. Next, hemochromatosis has micronodular cirrhosis versus Wilson's disease, which has macronodular cirrhosis. All these are the questions, and I know they are a repetition, but bache, these topics have been repeated, so we need to know them well. Macronodular cirrhosis. Next point, it is excessive copper deposition in the liver. So there is failure to incorporate copper into ceruloplasmin. So put a double star. Serum ceruloplasmin levels. Serum ceruloplasmin reduces. Therapy. It is the copper chelation therapy with penicillamine or trientine or zinc-based therapy. That's okay. Stains used for copper. There are again two stains. That is the modified porcine stain there are two stains, that is modified or seen and the rhodamine stain. Modified or seen stain and the rhodamine stain. This is Wilson's disease. Next point. This was a slightly new question in the sense that whenever we talk of types of collagen, we limit ourselves to type 3 being replaced by type 1. Now the answer in this case was 1:6. Answer was 1:6. Let us go a step further. In keloid, the ratio of type 3 to type 1 is 1:17. देखो बच्चे, you very well know that type 1 collagen is the most common collagen in the body. You know that. You also know that it has the highest tensile strength. It has a high tensile strength. You know these 2 points. Next, you know that type 3 collagen is present in granulation tissue. Type 3 is present in granulation tissue. So as granulation tissue progresses to scarring, type 3 is replaced by type 1 collagen. After 1 month, what is the ratio? It is 1:6. Versus in keloid, where that ratio is 1:17, versus keloid, where it is 1:17. Next point. Type of necrosis seen in autopsy post-MI. Myocardial infarction, I need not even discuss this, is coagulative necrosis associated with ischemia. Coagulative necrosis is the most common pattern of necrosis. It is the most common pattern, you know that. A special subtype of coagulative necrosis is Zenker's degeneration. A special subtype is Zenker's degeneration, which is associated with necrosis, associated with typhoid infection, typhoid, necrosis of the skeletal muscle predominantly of the abdomen, that is rectus sheath and diaphragm. You know this, a easy question. Next question. Immunoglobulin expressed on surface of B cells is IgM. Immunoglobulin on surface of B cells, IgM. This you know from physio also. This was comparatively easier. Last year, NEET as well as May AIMS asked you about T cell activation. So let us now have a look at B cell activation. B cell activation, which it can occur by two means. The T cell dependent activation versus a T cell independent response. B cell activation. This is the next prospective question for NEET also. So firstly, starting with T cell dependent activation. This is the stronger immune response. This is the stronger immune response where first signal is received when antigen binds to the B cell receptor. First signal is when antigen binds to the B cell receptor. Next, like in T cells, T cell activation needed two signals. Second signal is by CD40L present on T cells with CD40 on B cells. Next point, MEMS asked you defect in CD40 ligand. Defect in CD40 ligand was which disease? Hyper IgM syndrome. Defect in CD40L was hyper IgM syndrome. Next, the T cell independent response has a weaker immune response. No memory cells are generated and only IgM antibody is produced. Immunity is shut down. So immunoglobulin expressed on the surface of B cells is IgM. Next, this gets us to the next question, which is fully reversible once established or which is manageable by therapy. Instead of fully reversible, better words are manageable. Manageable by therapy is the hyperacute graft rejection. Why? Because hyperacute graft rejection, this occurs because of preformed antibodies. Hyperacute graft rejection occurs because of preformed antibodies, so it is fully manageable. Next point, you can be given this image and you can be asked what is it. Everybody, acute humoral, acute cellular graft rejection. I'm telling you the question is which type of graft rejection is this. Everybody, acute humoral, acute cellular, hyperacute graft rejection or chronic graft rejection. Answer. What you see here is that this is a glomerulus with some dense deposit occurring in capillaries around the tubules. देखो, these circles are the tubules. Some dense deposits are occurring in capillaries around the tubules. What is getting deposited? It is C4D deposition, complement factor 4D. C4D deposition in peritubular capillaries. C4D deposition in peritubular, that is around the tubules, peritubular capillaries associated with acute humoral graft rejection. Next point, answer. Now, this was a slightly new question, but we could have approached this by ruling out other options. Answer bache. I'm waiting for your answer. Steatoria with acanthocytes. Dekho, celiac disease, you knew almost everything about it. We discussed it in detail. Dermatitis herpetiformis, HLA DQ2, DQ8, 98% of the patients. The microscopy, proximal intestine is more severely affected. Whipples, you knew that it has a diagnostic biopsy. It is associated with past positive diastase resistant granules in macrophages in lamina propria. Next, agreed. Sushmita and Tejasvi agreed. Answer is D, A beta lipoproteinemia. A beta lipoproteinemia, let us have a quick look, is seen in infants with failure to thrive, diarrhea, vomiting, and fat malabsorption. It has fat malabsorption. So there is a malabsorption of fat soluble vitamins, that is vitamins A, D, E, and K. So the clinical features occur because of deficiency of vitamins A, D, E, and K. Peripheral smear shows acanthocytes with hemolytic anemia, reticulocytosis. Hemolytic anemia, so retic count is elevated and there is raised bilirubin. Vitamin K deficiency. Fat soluble vitamins were ADEK. So vitamin K deficiency shows raised INR, international normalized ratio, increased risk of bleeding. Vitamin E deficiency has neuromuscular symptoms like ataxia, muscle weakness, dysarthria, and diagnosis is by confirming the mutation of MTTP gene in these individuals. This is A beta lipoproteinemia. Next point. Again, an easy question. The examiner had very specifically asked you, Mendelian inheritance is seen in which disease? देखो बच्चे, Down syndrome is trisomy 21. You know that. Downs can occur by three means. Downs because of maternal meiotic non-disjunction. This was last year's PGI question. Downs because of maternal meiotic non-disjunction, Robertsonian translocation, or balanced translocation. So this is not Mendelian. Turners with mosaicism. Turners is 45XO. Mosaicism means there is presence of two types of cells in the same individual. Turners, it's not Mendelian. Huntington's with trinucleotide. Trinucleotide repeat disease itself is non-Mendelian. What is left is Fragile X syndrome. Fragile X syndrome is a trinucleotide repeat disease. Along with it, it is also X-linked in nature. So Mendelian inheritance, Fragile X syndrome. Next point, let us have a look at trinucleotide repeat diseases, an important flowchart. You know that Huntington's and Fragile X are both trinucleotide repeat diseases. Which trinucleotides are getting repeated? Let us start with Fragile X syndrome. Fragile X syndrome. It is the second most common genetic cause of mental retardation. So patient को कम ज्ञान था. Trinucleotides getting repeated, CGG, which are getting repeated in the non-coding region. The next disease where trinucleotides are repeated in non-coding, the same question was asked in PGI also, is dystrophia myotonica. This is an important flowchart for NEET. Dystrophia myotonica and Friedreich's ataxia. These are the trinucleotide repeat diseases. Friedreich's ataxia. These are the trinucleotide repeat diseases where the trinucleotides are getting repeated in the non-coding region. Next point, which are the trinucleotides? Dystrophia myotonica, it is CTG. dystrophia myotonica is CTG versus Friedreich's ataxia GAA. Easy to remember, gait is abnormal, GAIT, gait is abnormal, GAA versus Fragile X, in which patient को कम ज्ञान था. Just a way to remember. Versus the trinucleotide repeat diseases in the coding region versus the trinucleotide repeat diseases in the coding region, which are starting with the first one, that is Huntington's disease. Starting with Huntington's disease, where you very well know hunter keeps the animal in cages, so the trinucleotides getting repeated are CAG and spinobulbar muscular atrophy and spinobulbar muscular atrophy. Spinobulbar muscular atrophy. Again, the trinucleotides getting repeated are CAG. So I can safely say in the coding region, the predominant trinucleotide getting repeated is CAG. The predominant trinucleotide is CAG. Next point, answer. Non-fluorescent stain. Non-fluorescent stain is GIMSA. Whether you knew that, see, acridine orange and auramine, everybody knows are fluorescent stains. Everybody knows that. Non-fluorescent GIMSA. GIMSA staining, it is routinely used in hematology. Let us have a look at others. Calcofluor white. Calcofluor white. It is a fluorescent blue dye. It is a fluorescent blue dye. It is a fluorescent blue dye that binds to the polymers of amoebic cyst. Next, auramine rhodamine stain. Next is auramine rhodamine stain. It is used for acid fast bacilli using fluorescence microscopy. In hospitals where the patient load is higher, auramine rhodamine stain is used for acid fast bacilli. Next, last is acridine orange. This serves as nucleic acid selective fluorescent dye. This is a nucleic acid selective fluorescent dye. That is acridine orange. This acridine orange is used for cell cycle determination. This can again be asked. It is used for cell cycle determination. So a non-fluorescent stain, GIMSA. Next, this gets us to chicken wire calcification. Simple one liner. Anmol, bache, Amal, you confused modified rhodamine stain with auramine. So auramine rhodamine is for AFB, acid fast bacilli, in hospitals with high patient load. Please note, it is only useful because it has higher false negatives. So it is useful in hospitals with higher patient load. Next, chicken wire calcification, chondroblastoma. Nothing to explain in this. Epiphyseal bone tumor, chondroblastoma, and this is the classical chicken wire appearance. It looks like where we hold chicken, the chicken wire appearance, chondroblastoma. Next, again, which condition is associated with high retic count? Aplastic anemia, ACD, and nutritional anemias have a low retic count. An easy non-discriminatory question versus high retic count, which is seen in hemolytic anemias. Nobody would have gone wrong in this. Next, this was a topic which was repeated in all three papers, AIMS, PGI, as well as JIPMER. 80-year-old female, forgetfulness, no seizures. Which of the following is seen? And the answer is neurofibrillary tangles. So with respect to Alzheimer's disease, these are the same three slides I showed you, both in AIMS as well as the PGI discussion. Alzheimer's shows plaques and tangles. Plaques are composed of A beta, tangles are composed of tau protein. Next, Stain used, we use the silver stains, most common being Bilchowski stain. We use the Bilchowski stain. I'll show you that image. Next point, genetics of Alzheimer's. Please have a very good look at this slide. NEET exam question. APP, Alzheimer's is associated with 4 genes. APP, that is amyloid beta precursor protein. APP, chromosome 21. Chromosome 21, senile cerebral Alzheimer's. Next, early onset. Early onset is with PS1 and PS2. PS1 chromosome 14, pre-PS2, pre-senilin 2 chromosome 1, and the ApoE form which is on chromosome 19. This is the genetics. So 4 genes: amyloid beta precursor protein, amyloid beta. A beta deposit was with senile cerebral amyloidosis. You know it from immunity. PS1, PS2, chromosome 14 and 1, and ApoE chromosome 19. Lastly, these are the neurofibrillary tangles, which on the silver stain, which is the stain used? Bilchowski stain. Which on the silver stain, that is on Bilchowski stain, appear like this. This is Alzheimer's disease. Next point, child with bilateral conjunctivitis, fever and skin peeling. So all 3 hints, actually 4 hints, child, conjunctivitis, fever and skin peeling, is Kawasaki disease. What is Kawasaki? It is mucocutaneous Kawasaki. It is a mucocutaneous lymph node involvement in children. It is mucocutaneous lymph node involvement in children. It is a medium vessel vasculitis. You already know that. It is a medium vessel vasculitis. Next, mucocutaneous. The mucocutaneous sites of involvement are oral cavity, conjunctiva, and arthritis. Oral cavity, conjunctiva, and arthritis. At these sites, it causes a non-suppurative or a non-purulent involvement. Mucocutaneous lymph node. Most common group of lymph nodes involved are the cervical group, that is the neck. Most common are the cervical group of lymph nodes. Seen in children, usually after viral infections. That is, it will have a preceding history of fever. Is also associated with skin peeling. And coronary artery involvement. This is Kawasaki disease. Next point, again an easy one. Hereditary renal disease. Hereditary in a child with hematuria, keratoconus, hearing loss. I mean easy and non-discriminatory, Alports. I am not going into much details. It is a alpha 5 chain mutation of collagen type 4. So it's also called as Col4A5. That is alpha 5 chain mutation of collagen type 4. The most common symptom is SNHL, sensory neural hearing loss. SNHL seen in approximately 60% of the patients, versus the most common manifestation, which is microscopic hematuria. Please differentiate between a symptom and a manifestation. Hematuria is a manifestation versus sensory neural hearing loss, which is a symptom. Next one. So this was Alports. Diagnostic hallmark of Alports. You again know this. Diagnostic hallmark, basket weave appearance. Diagnostic hallmark of Alports is the basket weave appearance. Arising because of splitting of lamina densa. Basket weave. Please put a line on the side. You know this. Splitting of basement membrane, giving it a double contour or tram track appearance is MPGN. So do not confuse between the two. MPGN, it is splitting of basement membrane, giving it a double contour or tram track appearance. Tram track appearance. Next, glomerular pathology is indicated by, this is 2013 All India repeat question, standard, same repeat, dysmorphic RBCs. देखो बच्चे, dysmorphic RBC means the shape of the RBC is altered. If the shape of the RBC is altered, it means it was passing through the glomerular capillaries. So glomerular pathology is indicated by the presence of dysmorphic RBCs. It is indicated by dysmorphic RBCs. Next, this was first new question. I'm not sure if it is covered in medicine or not, but with respect to pathology, this was a new question. Anti-GQ1B antibody is not seen in. So let me tell you that it is seen in. These were the three options. The fourth option was the answer. It is seen in MFS, Miller-Fisher syndrome, GBS, Guillain-Barré syndrome, and Burkitter-Staff brainstem encephalitis. It is seen in these three. Associated with GQ1 anti-GQ1B antibody associated with acute paresis of the ocular muscle. Next, it is an autoimmune disorder that causes eye muscle weakness, that is paresis of the ocular muscle, that's the same, and in this the antibody interacts with peripheral nerve ganglioside GQ1B. The name told you that, anti-GQ1B, so it interacts with peripheral nerve ganglioside GQ1B. Next point, same thing we saw in PGI discussion, call Exner, same slides we saw in the AIMS discussion. So three papers, I'm copy pasting. This is the second topic which was repeated, call Exner bodies, granulosa cell tumor. Next, we have already discussed this. This is what a call Exner body looks like. This is a call Exner body, granulosa cell tumor, versus a Schiller-Duval body. You have RBCs in the center with an outer papilla of cuboidal. This is Schiller-Duval body. This was the one which was asked in PGI exam, and I showed you all three slides. Schiller-Duval body. Schiller-Duval body seen in yolk sac tumor, endodermal sinus tumor. Versus if you have this as an ovarian tumor, what you see here is central nuclei with clear cytoplasm around it. The whole slide is monomorphic. It has similar looking cells. Seminoma. If it is testis, seminoma. Ovarian counterpart of seminoma is dysgerminoma. Ovarian counterpart of seminoma, dysgerminoma. So this is what seminoma or dysgerminoma looks like. Three microscopies in ovaries, Kollexner, Schiller-Duval, seminoma / dysgerminoma. And lastly, the gross. This is a teratoma. This is a teratoma. What you see here are elevated Rokitansky protuberances. These are elevations which are present from the cystic area of the ovary protruding into the lumen. Rokitansky protuberances. Significance of Rokitansky protuberances, these act as the sites of malignant transformation. I want you guys to tell me which is the most common malignancy associated with teratoma. Most common malignant transformation associated with teratoma. Most common being squamous cell carcinoma. Most common being squamous cell carcinoma. Next, this gets us to our next question, that is, which does not spread through lymphatics? Basal cell carcinoma. Again, a repeat question. I think this was this NEET exam question which was repeated. Basal cell carcinoma. It is aggressive, locally invasive tumor. Aggressive, locally invasive tumor, but does not metastasize. Does not metastasize, so does not spread through lymphatics. And you also know that this is what it looks like. What you have here is the stratified squamous epithelium with basaloid cells arranged in a palisaded manner. Basaloid cells in palisaded manner with a clear retraction space. This is a clear retraction space around the tumor. This is what basal cell carcinoma looks like. This is BCC, that is basal cell carcinoma. Basal cell carcinoma. You had peripheral palisading of basaloid tumor cells with a clear retraction space, BCC. You already know that it occurs above the line joining the earlobe to the angle of the mouth. Most common location is face. 90% occur above it. Next is KB test or Kleher-Betke test. KB test or Kleher-Betke test. This is used for Kleher-Betke test. It is a blood test to measure feto-maternal hemorrhage. It measures the amount of fetal hemoglobin transferred from fetus to mother. It measures the fetal hemoglobin. It measures fetal hemoglobin transferred from fetus to the mother. So it is used to detect feto-maternal hemorrhage. Next point, an interesting question. Lady who underwent radiotherapy a few months back for breast cancer came with bleeding gums. Now there was low platelet, low hemoglobin, prolonged APTT, normal PT. Past history of preterm gestation. I want you guys to tell me this. I want you guys to tell me answer. देखो बच्चे, hemophilia A is out because of low platelets. This will not be associated with low platelets. This is out. Radiation side effects nahi. History of preterm gestation and stuff, radiation side effects no. DIC is out because of normal PT. DIC is out because of normal PT. So what we are seeing in this is low platelet count with isolated elevation of PTTK or APTT. What we had was low platelet count with isolated elevation of PTTK or APTT with history of preterm gestation. Answer APLA. Answer APLA. Perfect. Tejasvi and Ruby agreed. Answer APLA. Next, complete H mole. Complete H mole karyotype. Same question was asked in last year NEET exam also. 46XX. Dekho H mole. Let us have a quick look at it. Complete and the partial H mole. Let's have a look. Complete mole results from fertilization of an egg that has lost the female chromosomes. That is, it has an empty ovum. So genetic material is completely father derived. It is completely paternally derived. So complete mole, we have 23X with chromosome duplication leading to 46XX. Or it can be 23X or Y. It can be dispermy with empty ovum leading to 46XX or 46XY. This is complete mole versus a partial mole in which there is fertilization of an egg with two sperms. So ovum had 23X. Complete mole, the ovum was empty. Here ovum has 23X, which is fertilizing with two sperms associated with dispermy. So what are the combinations? 69 triple X, 69 double XY, or very rarely 69 XYY. That is partial mole. Easy to remember. Complete mole has 46 chromosomes, XX or XY, versus partial mole which will have 69 chromosomes. Next point, put a double star. This is the NEET exam question. Immunostaining for P57 gene. P57 is paternally inactivated gene. It is paternally inactivated, helps in differentiating complete from partial. How? Paternally inactivated means it is not expressed in the father, not expressed in paternal genes, not expressed in father, not expressed paternally. So complete mole arises only from father. So it arises from paternally derived genetic material. So in complete mole, P57 will be negative. This is important. This is important. Complete versus partial mole. Next, one of the most interesting questions I guess you had in the whole JIPMER paper. Sperm motility is reduced in all except common sense, long drive. We have ACs now. You know that hot environment or exertion, running, smoking it decreases the sperm motility. It is decreased in all except long drive. What I was interested, what it would, no, it is not abstinence. No, no, that is one of the mistakes many students would have made. But you're running. Acha, let us first start with running. Firstly, the joggers, don't worry about it, so motility is not reduced. It is running a minimum distance of 108 kilometers per week. That is more than 12 kilometers per day. It's crazy, and that too for 12 months. I mean, don't worry about it. Next, it peaks after 1 day of abstinence with infertility problems, but overall begins to decline after 2 days of abstinence. This is in people with infertility problems. After 2 days of abstinence, it starts declining. Among men with normal sperm, overall quality peaks 7 days after 7 days of abstinence, but declines after 10 days. So 7 to 10 days it peaks but starts declining after 10 days. So answer is not abstinence. The answer is long drive. That is the best answer. Sperm motility is decreased with abstinence after 10 days. Answer was long drive. Answer was long drive. Next, which has the least risk of cholangiocarcinoma? We have done this. All the risk factors of cholangiocarcinoma start with C. Hepatitis C virus, PSC, primary sclerosing cholangitis, Clonorchus sinensis infection, choledochal cysts. These are the risk factors. The next risk factor is Caroli's disease, which is not a risk factor, PBC. PBC, primary biliary cirrhosis. All the risk factors of cholangiocarcinoma start with C. So the answer was PBC. Next, a easy one. This question was a mixture of path plus physio. Road traffic accident, came in shock, multiple transfusions. False statement is, it is multiple blood transfusions are related to metabolic complications. You know that very well. We have done the list of metabolic complications repeatedly. So this is true. Crystalloids can maintain hemodynamic stability. This again is true. RBCs improve oxygen transport to tissue and increases hematocrit. We have seen this in blood banking. This is true. This is true. Stored blood has higher 2,3 DPG and shift to left. Nahi bache, it shows a shift to right. It has higher 2,3 DPG, so it shows a shift to right. The answer was 4. False statement is 4. 4. Next, an easy question. ANCA positive, lupus antibody positive, female है, ANCA positive है, lupus antibodies है, rash on face. Answer SLE. Nothing to explain. Answer SLE. Next, VNTR. The JIPMER exam asked you the full form. VNTR stood for variable number tandem repeats. It stood for variable number tandem repeats. Let us see what we mean by that. There is VNTR. It is a location in the genome where short nucleotide sequence, please note it is a short sequence, is organized as repeats. The short sequence is repeated. It can be found on many chromosomes. What is the significance of this? Significance of VNTR. Significance of tandem repeats, short nucleotide repeats being repeated. First is RFLP, restriction fragment length polymorphism. RFLP genetic markers for linkage analysis. All the words are important. Linkage analysis is performed by RFLP. Forensic investigations, that is DNA fingerprinting or COVID database. That is the significance of VNTR. Exam just asked you the full form. Next, patient with fever and shock. I know we had 2 to 3 questions with respect to PT, PTTK. PT and PTTK both were elevated. FDP and D-dimer is also raised. Diagnosis, DIC. I don't think anybody would have gone wrong. I am just giving you 2 additional informations. The most sensitive test for DIC is elevated FDP, fibrin degradation products. Elevated FDP is most sensitive versus most specific, which is the D-dimer test. Sensitive is elevated FTP, elevated fibrin degradation products, versus specific, which is D-dimer. Both the questions are prospective questions for NEET. Next, simple one-liner. Cancer cachexia is associated with TNF alpha. The whole pathogenesis of cachexia due to cancer is TNF alpha. And in this, the BMR, basal metabolic rate, is elevated. There is loss of both. Normally students can confuse it with it is only the loss of lean muscle or fat. No, it is the loss of both fat and lean muscle, and there is an increase in acute phase reactants. This is cancer cachexia. Next, again an easy question. Pheochromocytoma, RCC, renal cell carcinoma, and even cerebellar hemangioblastoma. Cerebellar hemangioblastoma. Standard question associated with VHL mutations, chromosome 3. Cerebellar hemangioblastoma. Cerebellar hemangioblastoma, von Hippel-Lindau mutation present on chromosome 3. Agreed. Next, in this we had something called as Bloom syndrome. Bloom syndrome, it is an autosomal recessive disorder with short stature, sun-sensitive red rash primarily over nose, mild immunodeficiency, type insulin resistance with type 2 diabetes, risk of leukemia, lymphomas, and male infertility. This is Bloom syndrome. That was the last option, Bloom syndrome. Next point. Before we go further, I want to discuss one more question with you. Just a sec. I somehow missed having that in the PPT. So let me write it for you. A patient diagnosed with Hodgkin's lymphoma. This is an interesting question because some of the faculties have, by mistake, I guess, given wrong answers. Patient of Hodgkin's lymphoma, hemoglobin 5.6, renal function test, and liver function test were normal. Renal function test and liver function test were normal. There is no bone marrow involvement. Question is, which is false out of these? Which is false? First option, transfuse packed RBCs to improve hemoglobin. Give packed RBCs to improve hemoglobin. Second option, search for autoimmune hemolytic anemia. Search for AIHA as a cause of anemia. Third option, leukodepleted blood to be given. I'm very curious, what did you mark in this? Leukodepleted blood to be given. And last option, irradiated blood to be transfused. Answer, bache. Answer. What will you mark in this? Patient of Hodgkin's lymphoma with these, no bone marrow involvement, renal function, liver function is normal, hemoglobin is 5.6. Packed RBCs can be given. This is true. Now, the trick in this question was autoimmune hemolytic anemia, the warm type. Cold type of AIHA is associated with Mycoplasma pneumoniae. Warm type of AIHA, it is associated with CLL, that is non-Hodgkin's lymphoma, and Hodgkin's lymphoma very rarely. Predominantly it is associated with non-Hodgkin's lymphoma, but it can be associated with Hodgkin's lymphoma rarely. So if I have a patient with low hemoglobin in either of the lymphomas, I will like to rule out AIHA. So this is true. Option B is true. Ankit nahi bache, B is true. Next, if you give packed RBCs in an immunosuppressed individual, it can lead to FNHTR, which is the most common reaction after blood transfusion. FNHTR, febrile non-hemolytic transfusion reaction. To prevent FNHTR, you can give leukodepleted blood. So option C is also true. Majority of you told me the answer either as B or C. Option C is also true. Answer is D, which is false. Bache, irradiated blood is usually given in transplant patients. Hodgkin's lymphoma is not an indication of bone marrow transplant. There is no bone marrow involvement. This is not an indication. Of bone marrow transplant. So answer is D. You will not be giving the patient irradiated blood. I hope everybody is comfortable with this. So in the JIPMER exam, we had about 32 questions. This was our 32nd question. We had about 32 questions from pathology. all three papers, AIMS 30 questions, PGI 29 questions, JIPMER 32 questions in pathology, and in this path was the rank deciding. Now coming to the Unacademy platform, bache, I'll be having numerous free special classes for NEET PG on the Unacademy platform. All of you are on my Telegram group, and I'll be giving you the links for the same. With from starting from June 28th. This is for NEET 2021. This is for January NEET 2021. I am starting a 6-month MCQ based quick pathology revision. I'm expecting more than 95% questions in pathology, both in November AIMS as well as January NEET 2021, to come from this MCQ based quick pathology revision program. It is starting on June 28th, and it will be for the paid users only. Those of you who are interested, you can have a look at more special classes, use the code for additional discounts and stuff. Next, with respect to all the 19 subjects, the foundation batch course, this was with respect to pathology in particular, and all 19 subjects will be covered. The batch course starting on 18th June. Pathology subpart in this will start from 28th June for the January NEET 2021. In these 4-5 months, it is sort of a MCQ based crash course in which all of us will take care of your 19 subjects. Done. So needless to say, bestest of luck for the results. Thank you and take care.